issues of training, and it cuts across. You know, there are things that affect county governments, there are things that affect national government, there are functions that are concurrent, and we need to isolate the gray areas and, you know, define responsibilities so that we don't have this overlap and blame game.
Right.
For example, the issue of training is a conversation we have had for the last 10 years. We, those who are serving in counties, were having a problem of us releasing doctors to go on study leave, paying their salaries, but those doctors are working in KNH training and working in KNH. KNH is making some income through the service those doctors are offering. MTRH, the same thing. KUTTRH. And when you look at the law, it is very clear that training is a national government function. But this is a function national government had not taken up. And this is what we wanted to have clear conversation with national government, with the ministry. And we also asked the minister that we really have to engage in sincerity and commitment. So because of all those many issues, we really need to have a conversation. The other thing that was part of what we really wanted to address is these issues of shortage of health workers. You know, while we have so many trained health workers out there, they have not been absorbed. And you see, counties were complaining that whenever we make an attempt to increase the number of health workers, counties are being branded as employment centers and expenditure centers. There is no way you want to have good health working system without human resource. And therefore, if you want to have human resource, you should be willing to spend on personal emoluments. And so these are the conversations we wanted to have with the ministry, with the unions, with counties, with Senate, and National Assembly.
Okay. In that 1 year, what did you agree would happen during that period of 1 year?
We agreed
when it comes to these matters.
We are going to resolve the issues of training.
Okay.
Yes. Whether there will be, and the reason why we wanted to engage all of us, you realize like National Assembly has the responsibility of budgeting.
Yes.
And that is why we wanted all of us to be on one table. So that if there is an aspect of budget, we are engaging with National Assembly and that committee and saying, for this item, we shall need an additional this amount of resources to resolve this problem. Okay. So the things we agreed is the issues of human resource. We wanted to resolve the issue of training. We wanted to resolve the issues of interns. We wanted to resolve the issues of additional health workers, both in counties and national government facilities as a referral hospitals in terms of those specialization. We also agreed that we must now formulate, all of us working together, a means of ensuring our facilities are equipped, considering the fact that it requires very substantial resources to do it. And we said all of us, putting our heads together, can think of innovative ways, you know, to resolve some of these issues.
So in that 1 year, if there were doctors who wanted to pursue further training and they've applied and they're due for further training, would counties continue paying them their salaries in that period?
As is, counties are still paying.
So this was to continue?
This was to continue as we work out. Because we could not shut the system, you know,
as we
and
wait
say
for
we are waiting for 1 year. No. We continue the way we are going, but now resolve the issues that have always been a thorn.
Okay.
Because part of the reason why doctors also sometimes go on strike is they say, I have worked for 4 or 5 years. I now want to make progress and specialize. But County A is not releasing me to go for study leave. You know? And counties blame Ministry of Health and say, you see, you are supposed to be paying for training. I want to release this doctor, but I want to get another doctor to take his space. But I can't because my payroll is overloaded.
So that was to continue?
Yes.
Internship, was it also to continue?
Internship is ongoing. I'm not aware whether internship has been stopped.
Okay. So that was also to continue?
Yes.
Medical cover and such other benefits for doctors, they were to continue?
Medical cover, you know, definitely is part of the benefits an employer has. It cannot stop until we have another arrangement.
So those are the issues that are now making the doctors to go on strike. Those particular issues that you talked about. Let's start with the interns. The doctors are saying that since September last year, the interns who graduated last year, about 1,000 of them, have not been posted to the facilities across the country. Are you aware of this?
I'm not aware, and I would say I'll not be really competent to answer that. Probably the ministry could. But I would say this, that I am aware that one of the challenges the ministry has had is that the number of doctors now graduating from our institutions has increased quite substantially. A few years ago, we only had doctors graduating from mostly our public universities. You now know that a majority of private universities have also gone ahead to offer medicine as part of their training. And the number of doctors, therefore, graduating has substantially increased. But in the opposite, the number of internship centers have not increased. We are still dealing with the same internship doctor centers that was only handling graduates from University of Nairobi, Moi University, and KUT TRH. Now we have almost 10 universities now offering medicine. The number of doctors who have come while the space for internship has not increased. But part of, and that's why I'm saying, the union should be really quite honest. You know, these are part of the things we discussed. And this is part of the things we said, the reason we want National Assembly to sit with us, is because we are aware you cannot do anything without resources. And part of the problems we're having is the number of internship centers. And we're saying the ministry should then put more resources now to develop more additional internship centers. What has the ministry done? The ministry has upgraded a number of facilities. They are now in engagement with counties so that some of the facilities can now be taken up as level 6 facilities run by national government. We were in Kisumu the other day with the Cabinet Secretary for Health. Kisumu County has presented a petition requesting national government to take over Jaramogi Oginga Odinga Teaching and Referral Hospital. The conversation is now ongoing. Probably that facility will now be onboarded among the national referral facilities. That creates a new internship center. There are conversations with county government of Kisii for Kisii level 5 to be upgraded to level 6. And there is now Odaya that is being mentored by KUT TRH. All this effort is to increase the internship centers and upgrade. You know, the challenge with health training is not like any other training. It's not a training where just people go and pass there and then just graduate. The person who is going to go there is the person tomorrow is going to handle your health. Is the person who is going to administer medicine on you. So the training must be proper. We must make sure it is up to the standard. And that's why the ministry would not be in a rush just to post interns, for the sake of posting, so that people can complete their 2 years, and then they're employed without necessarily going through proper training process. So
are you saying that at present, we only have 3 internship centers?
Not 3, but I'm saying the number of internship centers we have.
How many?
Cannot, I can't give
in Wasingishu, how many do you have?
It's MTRH.
Only?
Yes.
So in cost general.
It's cost general
probably. Only.
But it might not even do the entire internship program because there would be things that they will have to probably do it in some of the. Part of this is affected also by the equipment, and not just equipment, and also the level of human resource in that facility. Because we are sending a doctor, unlike other professions, an intern must work with an already specialized or trained person, hand in hand. And there can be only a certain number of interns per doctor, per session. Now, if you look at this country, the number of specialists we have in some specialized fields, we still have very, very low. And that is why, in the conversation we are going to have under the Human Resources Advisory Council, is how the ministry will then accelerate this process of people who want to specialize so that we have more people and open up more internship centers. And counties can then also be given opportunity now for service delivery at county not to suffer, the opportunity to even hire, those who have already completed internship. Now we're having a compounded problem. We have interns waiting to go for internship, but we have also those who have completed waiting to be posted.
Exactly.
Now you see, and that's why I'm telling the unions, these are conversations we could be having with them, that we also have to agree as a country that we cannot stick to the old way of doing things and expect things to change. We must now open up our minds and say, it is possible to hire doctors on contract. Because if I release a doctor to go for training, and this specialization takes about 4 years, Why should I stay without a doctor in a county for 4 years? And there's a doctor here who is just encouraging, you are forcing doctors now to engage in other businesses. Some are selling clothes, some are selling cars. We are making them begin creating new professions away from the professions they have done. Why don't we engage in a manner of saying, okay, maybe county A, you are not ready to increase the number of doctors because of the amount of resource available. But if ministry takes up this responsibility of training, why can't I feel this opportunity, even if it is for 4 years?
Right.
And by the time the other one completes and comes back, this one 4 years is now ripe to go and specialize. So
they'll swap.
Yeah.
Or how about you just outsource this entire human resource function to another unit, a health services commission, as they've proposed. So that way, all you do is post your needs to the Health Services Commission. I need a doctor.
You see, I will tell you this. It doesn't matter where it is going to be, the function is going to happen. The issue here is the resources.
Okay, so we've come full circle, I think, with that last statement that you've made, Senator. If the issue is the resources here, in terms of allocation, and in terms of priority of allocation, then it really doesn't matter who said what at the beginning of the year or whenever. That here we are looking at a situation whereby the deployment of interns, as they've been given postings, has not happened over 8 months. We're also looking at the same situation where the offtake of those who have finished their internship for postings after this year of specialization also has not taken place. We are dealing with other issues of medical care, medical insurance for medical workers that, yes, has lapsed. And we're still waiting for that to be sorted out. And you're dealing with a myriad of other issues, which then comes round to this last thing that you've said, because of resources. So the question really then at the heart of the matter is that in the case where allocation then has not been provided in the budget for these things, we should be asking the question at the heart of the matter, why? In terms of the priority of this allocation, why is it not being given priority? Because it's been budgeted. Ministry is aware that these things need to be done. So why is the resource issue an issue? And it didn't start in 2024. There is a CBA for 2017, which has not even been complete. It has not been enacted. So why is the
because I was a governor then.
Why is the resource issue an issue?
Didn't agree as Council of Governors then with that CPA. And the reason why we are saying we wanted to engage, and your questions are valid, we wanted to engage with the ministry, is we want to avoid this silo thinking and silo responses from a corner of this, a corner of that. You see, with that CBA, there was no way ministry was going to sign a CBA without involving county governments, while counties are the employers. You are forcing a salary increase over counties that don't have adequate resources to implement that. And it is not the complete absence of resources. We have resources available for the workforce that is already existing. We need additional resources for the additional workforce and interns that are coming.
So it's a resource issue.
Yes.
Why is there such a serious resource issue for something that we know? We know the numbers. We know the personnel. We are not saying blow up the thing by 100,000 doctors. You're aware of the doctors that are there. You're aware of the doctors that are needed. So the question is, why is there no appropriate resource allocation for the posts that we are aware exist?
But we are also aware,
Senator,
please.
I can understand the other things that we can be aware of. So many things, the day is long. But I'm just asking a simple question here, because I think it's at the heart of the matter. Why is there no priority allocation of resources for the needs we are aware, not even the ones we guess, that we are aware exist?
There is priority.
Is there?
If you look at the budget policy statement for this 2024-25 financial year, if you look at the key sectors, there has been significant increase of allocation. But even with that increase of allocation, it is not sufficient. And that's why I'm saying, as a country and as government, we really have to be realistic and practical. In this sense, let's use the resources available to try and make progress, as opposed to, making it difficult for us to utilize the available resources to make progress.
Can you paint a picture of what would make sense so that we would like to understand
what would make sense
reduce the number of doctors, reduce the number of hospitals? What are we talking about?
No. Let us be practical. Allow government to hire doctors on contract. Why are we fighting contracts? Allow county governments to hire nurses, clinical officers, public health nutritionists on contract in terms that are affordable. Why do we become so harsh on government that it is only in government where people want us to make employment permanent and pensionable, even when we cannot afford? Ask yourself, all these health workers who work in private hospitals, how many are on permanent and pensionable terms? In terms of remuneration, in private healthcare facilities compared to government, can you compare their remuneration? Even the terms that are being proposed by government and some county governments for contract is still far much better than what is being offered in private. I want to give you a very good example. Nairobi County now is suffering in terms of the requirement of human resource for its facilities. And Nairobi County carries a population of 5 million people. Nairobi County is willing to hire clinical officers, maybe nurses, and so forth on contract at probably a flat rate of about 40,000, 50,000 per month. But the unions have said it is not possible. The same health workers will go and work on private clinics and are being paid 20, 35,000. Why is it that it's only in Kenya where people who already have employment would not want to give a chance to even those who are outside there? Or what benefit will it benefit us to train nurses who will move around the market for another 3-4 years before they go back to get employment? By the time they get an opportunity to work, even those skills will have faded.
Senator, by the end of that statement, you've actually accused the government, national government, of not planning adequately. Because training has to do with the needs of a country. We plan to train certain numbers of people because we know how many there are. Ostensibly, it's supposed to meet the needs that we have in the country. If I look, for instance, since we're talking about the health sector, the recommended ratio of doctor to the population of people, according to WHO, as you will well know, is 1 to 1,000. Ours in Kenya is 1 to 17,000. Okay? Yes. Cuba is the country with the best ratio on the planet. It's 2.5 doctors to 1,000. So we are very far from even meeting the very basic needs that we have. The questions you raise I like because it gets to the heart of who holds the responsibility for what when you are making these decisions, and how collectively can we actually work to find a solution that we can afford and that is realistic. But you see, again, the planning, it's a national government function, and you talk about human resource in the country, again, it falls on their shoulders. And so when we talk about doctors, or we talk about teachers, we talk about, think of any cadre, we have a glut, it appears, and yet in reality we don't, because if you look at the ratio that is required, we don't have the requisite ratio that is actually needed to provide the services for the people. Now, it's a conundrum of sorts. It comes down again, resources.
But that is why we needed this period we have agreed as all stakeholders in the health sector. And for once, I will tell you, because I served for 10 years as governor. For those 10 years, it was difficult to have a meeting with the ministry, with counties, with the unions, and agree on something. Because the ministry would always have a divergent opinion.
Why?
Council of Governors would, of course, this devolution is not something that has been there. And when you transfer a function, and somebody remains there and doesn't move with that function, there will always be a fight to remain with something to do. That is what has been going on. But this time, I thought we had a very good opportunity because the ministers themselves now are willing and ready to sit. Council of Governors were in agreement that all of us, let us be coordinated by the Human Resource Advisory Council. The unions and us in Parliament had agreed that let us go and now put all those discussions, whether it is resources, whether it is planning, whether it is this, And remember, I said from my statement, we wanted so that every institution or sector, we don't want blame game. Once we finish that, we say, Minister of Health, you are supposed to do this. National Assembly, you are supposed to allocate this amount of resources. Senate, you are supposed to ensure counties do this. Council of Governors, you are supposed to do this. Unions, you are supposed to, we should be able to make progress. So to me, the issue of the strike is premature and preemptive in what had been planned for discussion.
How many months is it since you made that agreement?
That's about 4 months.
So for those 4 months, have you had a meeting?
We've not had a common meeting, but every sector of stakeholders have been working on the issues. We are supposed to now be convened by the Human Resource Advisory Council.
Okay.
Yeah.
Would you say that you've been hitting the milestones that you should have been hitting by month 4?
Yes, I would say that because if you look at us in the Senate, we were able to pass the conditional allocation bill. We were able to free additional resources to counties. We were able to make the money that was stuck in the ministry to move to now counties as part of our work and mandate in terms of legislation. We've seen the ministry now engaging with the Council of Governors, and if you look at the differences that has always been there, yes, there are still some differences and disagreements in a few or two things, but the beauty of it is that they are engaging. You know, you remember our first years of devolution. It was a press conference in the Council of Governors, and there's another press conference in the Ministry of Health, Halfway House, and then there was another press conference by the union in some corner. So at least, you know, as long as people and institutions are still engaging, we still think we can make a lot of progress.
Let's take a break. Let's take a break. It's 23 minutes to 10. Our guest this morning is Senator Jackson Mandago of Uasin Gishu. He has served as governor of that county for 2 terms. He understands very well when it comes about this issue of devolution and health and human resource and management and all, bringing us the perspective of your experience, which is a good thing, which is why we are engaging. Doctors are saying that they will go on strike come Thursday morning because of this issue of interns, because of the other issue of training, because of the other issue of shortage of workers and their medical care and their covers not being honored. And Mandago is saying, you know, actually, we had agreed we are not going to have this strike until we resolve these issues. The KMPDU Secretary General was here and he told us the same thing, that there was a meeting. They had even pledged that they are not going to go on strike, but they have noticed that nothing has been moving. In the meantime, they are still expected to go to work. Let's continue this conversation shortly.
This is the Situation Room, the only way to start your day.
I've got a plan to make my investment sizzle hotter than a Sunday barbecue grill. ICEA Lion has a plan for everyone. Talk to us today for a plan that's right for you. Or visit icealion.co.ke. ICEA Lion, what's your plan?
If you want your clothes and fashion gear to be so sexy that even your wardrobe blushes, what do? Buy tickets to a fabulous fashion show? See what the dedicated divas are wearing? None of the above. Because soon, the Nairobian will become the Nairobian Extra and give you TNX rated fashion live.
Welcome to the Delight Nakuru by Username Investments, going only for 799,000 shillings for an eighth of an acre. There's borehole water, estate gate, graded access roads, electricity and other social amenities.
It's 20 degrees. We'll see highs of 27 and highs of 30 in a sunny Nakuru at 21, coming down to lows of 14. It's sunny at 20 in Nyeri with highs of 27, while Eldoret will see highs of 27 where it's currently sunny at 19. 31 and sunny already in Mombasa with highs of 34, and we'll see highs of 34 in Malindi where it's sunny at 32. Kisumu is sunny at 25 and Kakamega is sunny at 24. Sunny conditions at 25 in Kampala, while Dar es Salaam is sunny at 30, 29 and sunny in Lagos with highs of 33, and Johannesburg at 20 is sunny, will go to highs of 29. Mogadishu at 31 and Addis Ababa at 20, while we're looking at a sunny Kinshasa going to highs of 34. It's 15 and sunny out in Beijing. Paris is 8 and cloudy going to 11, and it's a rainy morning in London with highs of 13, and still Monday night in New York coming into Tuesday, highs of 19 and lows of 6. Still really busy coming off the Thika Superhighway, especially right around the Pangani underpass, and that looks like it'll go through for some time as you try to approach the city, but you should be fine after that. Muranga Road then giving towards Globe Cinema at the overpass, very, very busy. And as you're coming on Uhuru Highway, getting past the University of Nairobi Junction and also crossing over from Parliament Road today, busy as well. Landis Road continues with traffic bumper to bumper through towards the Kamkunji roundabout. We're looking at traffic coming off of Juja Road as well. Apart from that, everybody seems to be in good stead. Let's keep an eye on things through the morning. Talk to us on SpiceFM KE on X.
Spice and everything nice. All right.
Spice up your life. Mature, intelligent talk every morning. Spice up yourself. Mornings done right. 94.4 Spice FM, Nairobi.
Continue our conversation with Senator Jackson Mandago of Wasting Issue, Chair of the Health Committee of the Senate. We are talking about our healthcare system. Approved internship training, excuse me. The approved internship training centers in the country are 73, and an extra 9 of them for dental. The 9 for dental are Coast General, Defense Forces Memorial, Jaramogi Oginga Odinga, Kakamega, Kenyatta National, Machakos Level 5, Moi Teaching and Referral, Nyeri County General, and Rift Valley County Provincial Hospital in Nakuru. So we have those 73 internship centers. Currently, the number of graduates who are waiting to be posted for internship are 1,219. They didn't just happen on government. The government knew all along how many students are pursuing medical. At the point they were graduating 7 years down the road, the government knew 7 years we're going to have 1,219 people who are seeking internship. It has posted 0 of those for the last 8 months, Senator. 0 have been posted. This 1,200 are the ones who are saying, we haven't been posted. What happens to us? We cannot become doctors until we go through this mandatory 1-year internship period. You cannot have a bigger pool of doctors to hire from as governors, not you as governor, but the governors cannot have, because 1,200 people are just there in purgatory, sort of. Is this a matter that really the national government should sit and say, oh, we are waiting to increase the number of internship centers? Is it a lack of planning?
As I said, I would not speak for the ministry, but I would also say that it's not just about the ones who are being posted, but are there interns also still undergoing their internship? So we cannot say it is 0, because there are those who are already on the internship. Posting is a continuous process, but the internship is also continuous, because there are already those who are on the internship programs. However, of course, the ministry ought to prepare better and make sure that those doctors, when it comes for internship, and it's not just about doctors only. We also have a number of cadres in healthcare who also require to go for internship. They have to have a better plan. And you see, you must start somewhere. And these challenges in government, they don't start today. These are built up. They are built up over time, and also to resolve them will definitely take some time. And that's why I would really have encouraged the unions that instead of the strikes and the demonstration, they should have initiated the process, of conversation. The union cannot also say that they will just go and sit there and wait for if we are truly engaging. If I see something myself in the ministry that I think is not going right, as Senate Health Committee, we shall write to the Cabinet Secretary. And ask why is this not happening. Equally, the other stakeholders should be able to be proactive. I mean, there are issues that each one of us brought to the table. It's incumbent on us as a Senate Health Committee, for example, to continue engaging the national government, the executive, in terms of increasing the allocation to counties, because we know the gaps in counties. So we have a clear-cut position in terms of we want to see this going to happen in counties. We want to see this additional going to happen. And like that issue of training, that issue of doctors going to specialize, we are very clear as Senate that national government must take up this responsibility. And that is why in our engagement ourselves, we are going to engage with national government with the mind that when are you beginning to take off?
To take over training.
Yes.
Okay. And
then go to the next level of now, can we be allowed? While these ones are on training, can counties be allowed? And now this is engagement between us, the Human Resource Advisory Council and the unions, that we have to have a meeting and agree that even if it is on contract, let's go in this type of arrangement in terms of contract.
Senator, what's your position on the call for a centralized health management system, human resource?
For health?
Yes.
I don't support.
Why?
And I have very good reasons. Why? One, the whole, and I wish the union, and next time, please, I would want to come to the studio, and also the Secretary General of the union is here.
We'll do that.
Especially on this debate of human resource and placement and so forth. You see, I've said before, it doesn't matter where the health worker is being managed which agency does what or what. If the resources are given, these institutions must be able to work. And I will tell you, the only reason doctors and health workers want to have a commission is because they want to avoid being supervised from the county. If you are not the one paying the worker, you cannot supervise. So let us not waste time. If health is devolved, let county governments be responsible for the health workers. Let the workers be paid, managed, and progress.
Are you saying that there can be no supervision when it's national?
You can't.
Or are we saying that with other commissions, there's no supervision of the workers? Other commissions that exist in this country, are we saying then that there is no supervision? Even though we accept that not all of those functions for which there are commissions are devolved, fine. But are we saying that there's no human resource function of supervision when a commission exists?
The difference between what is being proposed and the other commission is that for the others, the function is within that national government and is a straightforward and from one end to the end.
Okay.
For this one, there will be confusion. There will be a problem. Because there are functions that the counties will be expected to perform. You will expect this worker to direct this worker who is not your employee.
Is it not feasible to have a National Health Services Commission which is under the Council of Governors?
If it is going to
collectively, if
it is going to be managed by counties.
But then, even before 2013, when devolution kicked in, doctors were posted across the country by the national government. Was there no supervision?
There was a problem. I'll tell you.
How?
They were being posted, but they were not working in the stations they were. In Gishu County, when I took over in 2013, in our payroll, we had more than 23 doctors. They were not in our facilities. 4 of them were working for Oxfam somewhere in Somalia.
Why? What was the structure?
It's a question of supervision.
Was it a lack of structure for supervision?
You see, there was a complete breakdown in terms of supervision from the ministry all the way down there. And let me tell you, Eric, even if we have to have that commission, take for example Teacher Service Commission. I used to work in TSC. It was centralized there. Why did TSC as a commission decide they were going to recruit teachers at the schools, at the station? Because there was no teacher who was willing to be posted to Mandera. There was no teacher who was willing to be posted to Lodwar. And because we needed teachers there, what did TSC do? They said, fine, we have employment opportunities, but they are available in Mandera, they are available in Turkana, they are available in Wajir, they are available in Marsabit. So if you need a job, go and apply, bind yourself, you will work there for 5 years. That is how schools have been able to grow up and enrollment have been able to go. So when you centralize, and it is not that TSC was not recruiting, it used to recruit. But what happens? After 3 years, everybody is asking for a transfer. It is the same thing with health. Today, if you look at the amount of human resource in terms of health workers now in Mandera, Wajir, forget about, when we talk about devolution, there are counties you might not really probably feel the difference. That service delivery is still going on as it used to be. If you are in Nairobi, if you are in Nakuru, if you are in Wasingishu, if you are in Mombasa, if you are in Kisumu, if you are in Nyeri, the former provincial headquarters, the former municipalities. Yeah. Services had already been upgraded to some level. But if you are in Turkana, where we used to only have one facility in Lodwar town, Turkana County is 66,000 square kilometers.
It's huge.
It's huge. But today, in Turkana County, you have at least 1 or 2 health facilities in every ward. You have an ambulance in every ward in Turkana County. You go to Mandera, you go to Marsabit, that is it. That is the impact devolution has brought.
And they have hired doctors.
Of course.
Who are working and living there.
Yes.
Okay.
So if you make a mistake or bringing that commission people are proposing, somebody will sit there and say this doctor has applied for a transfer. Before you discover, you will not have doctors in some of those regions. Even as it was in Gishu, for example. When you post a doctor just from Eldoret town to Siwa Sub-County Hospital, which is just 40, they will still have a problem going to Siwa. They want to hang around here in town. And I think this is the nature of human beings. People want to wear services are good. Nobody wants to start. And I will tell you, Eric, today that Kenya has made tremendous progress. I don't see why people have a problem working and being managed from anywhere. You cannot compare the presence of government, the level of infrastructure to yesteryears. If you ask us, those who worked in government some years back, as young as we are, but we are not that young, there used to be days you are being posted. He knows to a station. You have there's no housing, there's no office. And some of these DCCs and some fellows, you are posted to a division, you have no office, you have nothing. You are going to start from somebody's home.
You actually go to look for a map to decide, to understand where this place you are posted is. Yes.
So I think we are better off. If the conversation will be COG will be responsible, so that it is among us the counties to decide without the involvement of national government, because we don't want a mix-up in human resource management between national and county. Then it will be better to end some of this confusion. For example, today we have interns that was hired during COVID by national government, posted to counties. Those people now are neither here or there. So, and those are part of the things we wanted to have that conversation in that meeting. Sort such matters and place the function where it's supposed to be. If the role of ministry will be to send resources to counties, let them send. Then if the role of counties is to manage, let them manage.
Is there urgency on the part of government, both national and county government, to actually address the issue of healthcare once and for all? And to sort these issues? It
is extremely very urgent. There is urgency in national government, there is urgency in Council of Governors and counties.
Is there commitment and goodwill?
Absolutely, there is commitment. And I'll tell you, there is commitment right from the president. In fact, we have a chance because we have political goodwill this time round. Counties and national government and the Ministry of Health, there is no way we can talk of universal health coverage without resolving some of these issues. In fact, from where I sit myself, this plan by national government, this agenda that Kenya Kwanza has put as a priority, is actually a catalyst to solve some of the historical problems that we have had in health. Because this program will not succeed until we also sort out the issues that surround human resource for health. So it's a good opportunity. And I believe there will be a middle ground where Council of Governors will cede some ground, and also national government through the Ministry of Health will cede some ground, and the union will also cede some ground, and we should be able to begin somewhere. I think this is a golden opportunity.
What do you think will happen in the coming days? And I need to be very clear about that because the unions, and it's interesting because the doctors and dentists union is at the forefront of this conversation, but other medical personnel who have had issues over the last few years, not just months or days. We've heard clinical workers saying they want to go on strike. We've heard nurses saying they want to go on strike. Across board, it continues to be a conversation. And I know you said, well, they need to be given some time, 2 days, 3 days, 3 months, we don't know. However, the strike notice comes to an end tomorrow. And from where the doctors are coming from, unless something is done, or at least some kind of commitment is shown, they will go on strike come Thursday. And it would be a terrible situation because we've seen what that can be in this country. So as a matter of urgency, what do you think needs to be done now? Apart from the doctors giving the ministry an opportunity or a chance.
One, since the matter is already out there and the doctors have issued notice of strike, the Human Resource Advisory Council can then convene all those stakeholders and engage on that matter. But I would also say that even as we engage, the doctors had already even there was a demonstration that happened, and it's quite unfortunate that our friend SG was also injured in the process. That really we should give priority to dialogue, especially where every partner has said we are willing. We have stopped our hardline position. If you look at CUG today, for example, the functions are very clear in law, what has been devolved. But you can see Minister of Health is still, doing the function of that hiring of those contract workers that were in counties. But Council of Governors is saying, okay, fine. Although there's been that problem, can we now come and engage so that we properly align? So I would urge the chair of the Human Resource Advisory Council, because we had all mandated them to convene us, because we were looking for a neutral arbiter between Council of Governors, we ourselves in Parliament, and the executive in the ministry. And the agreement in the selection of that Human Resource Advisory Council committee was by consensus, and it was agreed upon. So in this situation where we are in, to avert the strike and probably bring everybody on the table, and so that we can also have an opportunity to listen to the doctors when they say the ministry is not committed. We would want to know what is it that the ministry is not doing, because Parliament can also take up that in terms of oversight function and ask the ministry, if you are supposed to have done this and this and you have what is the problem? Because they cannot tell us they don't have resources, because we can quickly check in the budget and tell them we have allocated you this amount of resources. You should be able to move. If it is negligence, if it is inefficiency, should be dealt with.
Well, Senator, we thank you very much for joining us today. Let's see what happens come Thursday. We'll invite you, like you've said, we'll invite you again with now the Secretary General of the Kenya Medical Practitioners and Dentists Union. Let's discuss this issue of health resources, even the issue of contracting health workers. What you think, why you think it's a good thing, why they think it's not a good thing. Let's have this national conversation because it's important. Senator Jackson Mandago is the Senator for Uasin Gishu County and the Chair of the Senate Committee on Health, former Governor of Uasin Gishu for 2 terms. Thank you very much for tuning in to Kenya's biggest conversation, The Situation Room. We'll be back tomorrow morning, God willing. It's now 10 a.m. Good day.
Thank you.